Can I start, sir?
Yeah, Shishir, you can start.
Good morning, everyone. 36-year-old female patient presents to OPD, hailing from Miraj, presents to OPD with chief complaints of mild pain, redness, and diminution of vision from left eye since 3 months. History of presenting illnesses. Patient was apparently all right 3 months back, after which she developed mild pain and redness in left eye. That was gradual in onset and progressive in nature. So the pain was dull aching type, which was present throughout the day, associated with mild redness. And here aggravating factor was uh, like in the evening, the pain used to slightly worsen, and relieving factor was when she takes painkiller medications, so temporarily pain was relieved. So after a few weeks, patient started developing diminution of vision in left eye. That was gradual in onset and progressive in nature. So patient consulted ophthalmologist, after which she started using eye drops and tablets. So the eye drops was used 4 times per day and tablet twice a day. So the details of which are not known to the patient. And patient got relieved of pain and redness temporarily. She was on medication for 2 to 3 weeks, and again symptoms reoccurred after stopping the medications. So the patient says that after stopping after 10 days, around 10 days, the same redness and pain she started having again. So on further history taking, patient also complains of recent onset headache in the frontal area, which was present occasionally for 2 to 3 hours a day and subsides after taking medication. So that 2 to 3 hours was irregular. Sometimes she used to get in the morning and some other times in the evening. It was not specific time of the day. So patient is not a known case of diabetes or hypertension or any other illness. So there is no history of any ocular discharge, no history of trauma, no history of foreign body fall, no history of swelling around the eyes or outward protrusion of eyes, no history of diplopia and colored halos. So, no similar complaints in the past. This was the first time the patient was experiencing these complaints. And there is no history of joint pain, back pain, fever, cough, weight loss, nausea or vomiting, skin rashes or discoloration. And there is no history of close contacts with pets. So, patient is not on any chronic medications in the past. So again, past history, no similar complaints in the past. So family history, no similar complaints among family members either. So coming to personal history, patient is having mixed diet with adequate appetite and good sleep, normal bowel and bladder, and no habits of smoking, tobacco chewing, or alcohol consumption. Systemic examination appears to be in normal limit. So coming to visual acuity, so I'll be describing about right eye first, left eye first. So in left eye visual acuity, best corrected visual acuity is 6/18, and IOP measured by eye care rebound tonometer at 11:50 a.m. It is 17 millimeters of mercury. So gross examination, eyebrow appears normal, eyelid and eyelashes are normal, orbit and sac area appears normal, eyeball alignment is orthotropic. And coming to ocular examination proper, so in the left eye cornea, it reveals like circumcorneal congestion present, and with diffuse small multiple deposits over the corneal endothelium, which are present at the inferior half of endothelium, suggestive of keratic precipitates. Anterior chamber reveals 2+ cells, and pupil, it is round, regular, and reacting to light. Lens and anterior vitreous So lens was clear, grayish black, and in anterior vitreous, grade 2 to grade 3 cells were present. So coming to fundus examination, so these are the images of both eyes. So in coming to left eye, so disc size appears normal, shape appears circular, with cup disc ratio of zero point 0.2, with healthy neuroretinal rim, and blood vessels are arising from disc and branching dichotomously to maintain an AV ratio of 2:3. So, coming to the foveal reflex appears to be dull, and you can see multiple subretinal nodules around 1 disc diameter in size, circular in shape, distributed throughout the fundus, including the posterior pole as well as few you can see in the mid peripheral area. Uh, so these are subretinal because you can see the vessel is crossing over this lesion. So this the level of this lesion is subretinal, and peripheral retinal examination appears to be normal. So left eye, best corrected visual acuity is 6 by 6 parts, and intraocular pressure is 17 millimeters of mercury, and eyebrow, eyelashes, orbit, and sac area are normal in in right eye. And cornea, there is circumcorneal congestion present in right eye, but no evidence of keratic precipitates. And anterior chamber reveals 1 plus cells, and pupil is round, regular, and reactive to light. Lens and anterior vitreous clear lens, and there is grade 1 cells in anterior vitreous. So coming to fundus examination, so again, size shape of the disc is normal, with point 0.2 cup disc ratio with healthy neuroretinal rim, and blood vessels are having AV ratio of 2:3. And again, coming to macula, foveal reflex appears to be dull. And in the background, again, you can see multiple subretinal nodules around 1 disc diameter in size, almost circular in shape, scattered throughout the fundus, and peripheral retinal examination appears to be normal. So this is the OCT image of both the eyes. So in right eye, the OCT image appears to be normal, whereas in left eye you can see the cystic space, intraretinal cystic space suggestive of cystoid macular edema, and rest of the OCT remains appears normal. So the investigations was following investigation was advised. So you can see there is a rise in the total leukocyte count, and mild rise in platelet count as well. And again, C reactive protein levels are raised. It is 8.7. Then other routine investigation for uveitis appears to be within normal limits. Tuberculin test is also negative. So my provisional diagnosis based on clinical examination is bilateral panuveitis due to probable Vogt-Koyanagi-Harada disease. It is not complete VKH disease. It is probable VKH disease. So the differential diagnosis of this case would be posterior scleritis, acute posterior multifocal placoid pigment epithelopathy, birdshot
So,
chorioretinopathy,
Shishir,
multifocal.
while
Yes, sir.
describing the DD, just tell in brief like why it is not posterior scleritis.
Uh, Posterior scleritis, again, it is actually common among female, but posterior scleritis generally it is unilateral, and the anterior segment in reaction will be rare. It can be there, but it is very rare. And in fundus examination, again there can be disc edema and choroidal thickening also. The main investigation is you can do B scan to rule out to differentiate between VKH, where in posterior scleritis you can see the uh, thickness in subtenous space, the fluid accumulation in subtenous space leading to classical T sign, which you will generally not see in VKH. Uh,
In this case,
so
B
this,
scan was done.
sir, B scan was not done, sir.
Okay. So without B scan, why you have ruled out posterior scleritis?
Uh, Sir, in posterior scleritis, there will be pain on movement of eyes also, sir, and
Hmm.
there was presence of panuveitis like picture, which is not commonly seen in posterior scleritis. So, and pain may radiate to jaw also, jaw and neck also. So there will be severe pain, which
Yeah.
was
So
not so
generally,
in this patient.
the hallmark of posterior scleritis is significant pain, which was, I think, not the case here.
Not
Okay.
yes.
Next, acute APMPP.
Uh, so, uh, uh, sir, you can hear, sir?
Yeah, I can hear. Next, DD APMPP. What? Why it is not APMPP?
Uh, so this comes under the spectrum of white dot syndromes, where in which you will see multiple creamy, whitish or cream-colored lesions in the posterior pole. So that was not seen in our case, and this may have the other features like vitritis and all, but it will have painless sudden onset of diminution of vision.
Yeah. So generally, it is painless, and usually on OCT you see
Yeah.
neurosensory detachments. Here, I think it
Oh,
was cystoid macular edema, right?
yes, sir. Here it was cystoid macular edema.
Okay. ठीक है. But yeah, APMPP again. If for APMPP we can do FFA and check for its typical early hypo followed by hyper lesions. APMPP
Yeah.
more common lesions are in the posterior pole. I think here it was more in the mid periphery, right? Can you
Mid
show the
yes,
photo
sir.
again? I think these are more of mid peripheral.
Yes, sir.
Posterior pole is not actually involved here much. Okay, next, DD.
So birdshot chorioretinopathy, again, it is choroiditis. Choroiditis like picture. It is generally unilateral. Uh, Again, there may be neurosensory detachment in the retina. So the inflammation is restricted to posterior segment only. Yeah.
Okay,
So again, multifocal choroiditis and panuveitis, it will involve all the entire uvea, but again, it is I think commonly seen unilateral case.
okay,
And UEL effusion syndrome, here there will be detachment, ciliochoroidal detachment is seen, but the differentiating point is there is no inflammatory component in UL effusion syndrome. It is due to the blockade of the drainage from posterior segment. So the vortex vein get occluded uh, due to the scleral thickenings.
Right. UVL effusion more common in nanophthalmic eyes, but
Yes.
there is a UVL effusion syndrome also where it may be occurring in otherwise normal eyes. Also,
Oh,
post-surgical UVL effusion after nanophthalmos is also common, but inflammation is not much, as you said.
and CSR, because if you see in OCT, CSR also has a neurosensory detachment with there might be associated pigment epithelial detachment also. It is important to rule out CSR because the treatment in CSR is to stop steroid, but in VKH you have to give steroid. So uh, in that sense, it is important to rule out CSR where there won't be any inflammation or any any exudative lesions. You will see the neurosensory detachment only, and anterior segment generally appears normal. And
Yes.
sympathetic ophthalmia also has a similar presentation as VKH, but sympathetic ophthalmia to diagnose there should be a history of penetrating trauma, especially with metallic foreign body associated with metallic foreign body. So which was not the case here.
Yeah, history of trauma is important in sympathetic ophthalmia. So here, apart from OCT photo, no other investigation was done.
No other investigation was done, sir. Uh,
FFA was not done.
No, sir. Actually, she was not willing for any investigation, so we only convinced her for OCTs.
Okay. What's next? You have started treatment based on this.
Based on this, we started systemic steroids, that is Vicelon, starting from 50 mg. Two weekly taper we have started, sir, along with calcium and antacid supplements we have started, sir. And patient was followed after 2 weeks. So after 2 weeks, anterior chamber reaction was almost zero point 0.5 cells, zero point 0.5 to 1 cells only, and even vitreous reaction was one grade 1 cell only. The visual acuity improved to 6 by 6 partial in the left eyes. And again,
Okay.
we had called her after 15 days. She did not come, sir, till now it's been 1 month that she didn't come. Only for first follow-up she had come, sir. She was symptomatically also was better.
Okay. One more thing I think we have to keep close watch on is the ocular TB. Though here the hallmarks of ocular TB are not there, like retinal vessels appear normal, right? Can you see the fundus photo again? Yeah, these subretinal
Yes, sir.
lesions.
Vessels.
Yeah, you
Yes,
like TB granuloma can be one of the DDs, but usually it's associated with retinal localized inflammation, which is not here in this case. Usually there might be associated vasculitis or retinal hemorrhages, which are generally seen, which is not the case here. But that should be kept in mind as a DD
yes,
in case like it recurs or it
indeed.
again increases later. Then it can be a ocular tuberculosis, which is masquerading as VKH or probable VKH, basically.
Weak. Yes.
Okay. Okay.
So, yes. Brief description about the case. So it is an idiopathic multisystem autoimmune disease featuring inflammation of melanocyte containing tissues such as uvea, ear, and meninges. So it predominantly affects Japanese pigmented individuals. So it is associated with HLA-DR1 and HLA-DR4 across different racial groups. So clinical features. So there is a prodromal phase which is lasting for few days. So where neurological symptoms like encephalopathy, cranial nerve palsies, and other focal lesions may be seen, and auditory manifestations such as tinnitus, vertigo, and deafness. So here cranial nerve palsies and optic neuritis may occur. So, and in acute uveitic phase, there is bilateral granulomatous anterior and multifocal posterior uveitis with diffuse choroidal infiltration known as Dallen-Fifth nodules. Vitritis, papillitis, and exudative retinal detachment may be seen. And there is ciliary effusion with iris lens diaphragm rotation can occur. So this will occur if the inflammatory infiltrates are present in the ciliary body. So then this might occur, and it might push the anterior. It might push the iris lens diaphragm anteriorly and lead to angle closure glaucoma also. So that is one of the complication associated with VKH. And so the diagnostic criteria, so this is modified diagnostic criteria. So there should be absence of history of penetrating ocular trauma and absence of other ocular disease entities. And there should be presence of bilateral uveitis. Neurological and auditory manifestations may be there, and integumentary findings that should not be present before the onset of CNS or ocular disease such as alopecia, poliosis, and vitiligo. So for complete VKH disease, all the five criteria should be met. For incomplete, first three should be met, and either four or five, one of four or five should be there. For probable VKH, there should be first three criteria should be met. So in our case, first three criteria are present, though fourth and fifth are not.
Neurological, I think she has
So
headache. I think, but
yeah, sir. Only headache she's having, sir. No,
mm,
no history of neck stiffness. Only headache.
okay. Mm.
So this is a typical fundus appearance in case of VKH disease. So you can see here uh, multiple areas of neurosensory detachment. So this is accumulation of subretinal fluid leading to exudative retinal detachment. So here you can see the skin findings such as vitiligo and even poliosis. So convalescent follows several weeks later. Characterized by alopecia, poliosis, and vitiligo, and depigmented fundus appearance, also known as sunset glow fundus, and depigmented limbal lesions, known as Segura sign, in pigmented, especially Japanese patient. So since there will be damage of the pigment. So in the later stages, you will see the depigmented lesions. And the chronic phase is characterized by smoldering anterior uveitis with exacerbations. So recurrent posterior uveitis is less common. Uh, Here you can see sunset glow fundus. So it is more commonly seen in inferior quadrant, where you can see multiple hypopigmented lesions. So this hypopigmentation uh, can be due to RPE atrophy and loss of melanocytes in choroid. So complications are choroidal neovascularization, subretinal fibrosis, and pre-retinal and disc new vessels and vitreous hemorrhage. Even cataract and glaucoma can also happen. So investigation. So if you check for CSF, it will show lymphocytic pleocytosis and melanin-containing macrophages. And fundus autofluorescence demonstrate areas of serous detachment. So in OCT, you can quantify the subretinal fluid, and you can also monitor monitor in the follow-ups whether the patient is responding to the treatment given by us. And ultrasonography, it will show choroidal thickening and excludes posterior scleritis. And UBM can also be used to demonstrate ciliary effusions. So, fluorescein angiography of acute phase, it shows multifocal hyperfluorescent dots at retinal pigment epithelium, followed by subretinal pooling. The chronic phase may show RP window defects due to atrophy of RP. And ICGA shows regularly distributed hypofluorescent spots, most of which remain hypofluorescent during the late phase as well. So, when diffuse hyperfluorescence over the posterior pole is also seen. So ICJ is useful for monitoring. So again, these are the various investigations. So first one is fundus autofluorescence showing subretinal pooling. And this is OCT where you can see multifocal subretinal detachment. Um, so this is the early to mid phase of fluorescein angiography, where you can see multiple pinpoint leakages, and in the later phase you can see subretinal pooling. So treatment is high dose. That is like you can start with uh, some people say you can start with 3 days of intravenous methylprednisolone, that is 1 gram per day, and then put the patient on high dose oral steroid, that usually 1 to 2 milligram per kg per day, tapered over 3 to 6 months. So generally, 3 to 4 weeks we will keep the full dose. Then after 3 to 4 weeks we will start tapering, and it has to be slow taper over 3 to 6 months. And topical steroids and cycloplegics are used for severe anterior uveitis also. And the indication for immunomodulators are if the patient is having severe adverse effect due to steroid, or if the patient is steroid resistance. So in such cases and in recurrent cases, you can use the immunosuppressives. So commonly used immunosuppressive are methotrexate and cyclosporin, and other biological blockers such as infliximab can also be used. But they should be limited to only non-responsive or recurrent phase. Ah, thank
So, take home point, one of the most important thing is slow taper of steroid, because commonly in other choroiditis or other anti-uveitis cases, we taper the steroids usually in 3 to 4 weeks time, but here it has to continue for 6 months. So generally, if we have confirmed diagnosis of VKH, we can, after initial dose of steroids, once the disease subsides, we can then start immunosuppressives, and then you can uh, reduce the steroids in next 2 to 3 months time, because steroid for 6 months have more side effects. So we can just shift to methotrexate, and then after 6 to 8 months of methotrexate, then we can try stopping it to check if there is any recurrence of VKH. So VKH recurrence is common, so that is something we have to warn the patient. And VKH
you.
is a vision threatening condition. That means patient can go completely blind if the disease is not treated in time.
Yes.
Generally, VKH in elderly is sometimes stronger, and it may be bilateral. Elderly means 50s, 60s, where I have seen that exacerbations are common. But young patients also should be careful, because if there is patient is not on treatment for some time, it may affect the optic nerve and can cause permanent loss of vision.
Yes.
So I think VKH is one of the diseases where we consider immunosuppressives early on once the diagnosis is confirmed.
Mm.
Okay. Any questions? Go back to the slide of angiography. Kishan, nahi, show the photo. Yeah, Kishan, can you tell me why this is a FFA and not a ICG? Sorry, can't hear. Shishir, can you repeat what he says?
Sir, disk is normal in FFA and disk is darker in ICG, sir.
So that is commonly asked questions during exams. Okay. And what is the topmost picture showing?
ICG, sir. Autofluorescence.
Hmm? It's not.
Autofluorescence, sir.
It's sort of. It's not ICG. Okay. Fine. So all of you should know FFA different phases. You can today write and post on the duty group. FFA, what are
Sir,
the phases? ICG, what are the phases? Time duration, and what are the different diseases which are typically picked up in different phases. Okay.
sir, I have a question. Sir,
Hmm.
hello.
Yeah.
Sir, what is the criteria of vision to start IVMP? Because this patient had 618 vision. So could
Hmm.
IVMP have been started first in this patient?
Yeah. So if the diagnosis is confirmed here, I would have done FFA to confirm that it's sympathetic apnea. This only VKH only, and ocular TB is not there. And then I would start with IVMP to begin with, because that will reduce the symptoms immediately, and after that we can continue with the steroids.
And sir, one more question. Sir, in OCT, I had read that inner retina is generally normal and there is accumulation of fluid in the outer retina with septate.
Hmm.
So, is it like, but in this case, we have seen cystoid macular edema and involvement of inner retina. So, how does it correlate? Like,
This uh, this is not
and
very typical VKH. CME is secondary to inflammation, intraocular inflammation, so it is just a sign of intraocular inflammation, not consistent, like not specific with any of the choroiditis. It may occur in any. So basically, I think she has been partially treated. So maybe the way she has presented is different, and it's kind of a milder form of VKH rather than very severe form of VKH. So I think the plaques are also very less in numbers all over. So probably it is
and sir, is
evolving VKH. So if she either after steroids she may resolve, but there is a high chance that she may recur, and it might be more severe next time.
sir, is unilateral VKH a known entity or is it uh,
Rare,
rare? Okay,
it's rare because
okay, sir.
VKH is basically the body is acting against the pigments. So wherever the pigments are there, it will affect it. So unilateral is will be rare because both eyes have same structure. So unless it is immunologically blocked because of some reason, it will affect both the eyes.
Thank you, sir.
Okay. Shishir, any other questions?
No, sir.
Okay, okay. Thank you. Good presentation. Thank you.
Thank you, sir.